You know that headache? The one that's not your typical migraine, not that throbbing behind your eyes. It's that nagging, deep ache that feels like it's coming from the base of your skull, maybe even from your neck, and just wrapping around your head. You've tried everything, but nothing seems to get to the root of it. Well, what if the problem isn't actually in your head at all? What if the real culprit has been hiding in plain sight this whole time? We're talking about your neck, your cervical spine. Today, we're going to dig into two very common but very different conditions that cause this exact kind of pain. All right, first up, we've got what's called a cervicogenic headache, or CEH. Now, the key thing to get here is that this is a secondary headache. That just means the pain is referred. The problem isn't where you're feeling the ache. The problem starts in the joints or the muscles of your neck, and that pain signal is just getting bounced up into your head. And then there's our second suspect, occipital neuralgia, or ON. This is a completely different beast. This one is all about sharp, zapping, shooting pains in the back of your head. The source here isn't a joint, it's the occipital nerves themselves that are irritated or getting pinched. It's a true nerve pain. So, you see, they can feel like they're in the same spot, but underneath the hood, they are fundamentally different problems. And knowing that difference, well, that's everything when it comes to finding relief. Let's break this down a bit more, because it's really the crucial point. A cervicogenic headache is what we call nociceptive pain. Just think of it like a perfectly good alarm system that's correctly reporting a problem, like irritation, in the tissues of your neck. Occipital neuralgia, on the other hand, is neuropathic pain. Here, the alarm system itself is faulty. The nerve wiring has a glitch, and it's sending out false pain signals. So, to get you the right treatment, your doctor has to basically become a detective. They have to crack the code of your pain to figure out which of these is the real cause. And all the clues they need are hidden in the details of what you're feeling. Now, one of the biggest points of confusion is mixing these up with migraines. But look at this comparison, it really clears things up. A cervicogenic headache usually starts in the back of your head with a steady, dull ache. And here's the dead giveaway, it often gets worse when you move your neck. A migraine, that usually starts up front, has that awful throbbing, and isn't really triggered just by turning your head. And for occipital neuralgia, this picture says it all. You can see the greater and lesser occipital nerves branching up the back of the head. When these guys get angry, they send those lightning bolts of pain right along their own pathways. It's not random, the pain literally follows the nerve. So how does a doctor pin this down for sure? Well, it all starts with them listening carefully to your story. Then they'll do a physical exam, checking how your neck moves and pressing on those spots over the occipital nerves to see if they're tender. But the gold standard, the test that really seals the deal, is what's called a diagnostic nerve block. A diagnostic block is actually a pretty brilliant idea. Think of it like flipping a circuit breaker in your house to find out which fuse is blown. A doctor injects a little bit of numbing medicine right at the suspected spot, the nerve or the joint. If your pain suddenly disappears, even for just a little while, boom, you found your culprit. Okay, so once the source is found, the real journey begins, the path to relief. And it's not a one-shot deal. It's more like climbing a ladder, starting with the simplest, most conservative steps first. The first step on that ladder is always the foundation. Just understanding what's going on and learning self-care, like fixing your posture at your desk. If that's not quite enough, you move up to step 2, maybe some targeted medications and physical therapy to work on those neck muscles and joints. Then you might try something like a TENS unit, which uses a gentle electrical buzz to scramble the pain signals. It's only after those steps that you start to consider the more advanced, interventional treatments. And I really want to highlight this quote because it's so important. With these kinds of chronic headaches, the whole game is about fixing the underlying problem, not just covering up the pain with powerful drugs. That's why opioids are generally not the answer here. The focus is on long-term, targeted solutions. So, what happens when you've done the physical therapy, you've tried the medications, and it's just not cutting it? Well, that's when we move up the ladder and start talking about treatments that can precisely target the pain right at the source. It's a really common situation, right? You've done everything right, you've been to physical therapy, but that pain is still there. This is where that diagnostic step we talked about earlier becomes the absolute key to what comes next. And that's where the nerve block makes its return. See, it's not just for diagnosis. The results of that block become a roadmap, pointing the way toward the most effective long-term treatment for you. So the big question is, did it work? Did that numbing shot give you even a few hours of blessed relief? If the answer is yes, that is a huge green light. It tells your doctor they're on the right track. A yes to that question opens the door to treatments that can last for months, sometimes even longer. The next logical step for a lot of people is a procedure called radiofrequency therapy. It uses a very precise electrical current to basically stun the problematic nerve or joint, quieting it down so it stops screaming pain signals for a good long while. And this is where that specific diagnosis becomes absolutely critical. If you have a cervicogenic headache, the treatment will likely target the tiny facet joints in your neck. But for occipital neuralgia, you can't do that. The problem is the nerve itself. So a gentler technique called pulsed radiofrequency is used, which soothes the nerve without damaging it. And for the toughest cases of ON that don't respond to anything else, there's even an option like an occipital nerve stimulator, which is kind of like a pacemaker for the nerve. So we've been the detective, we've looked at the clues, and we've walked up the treatment ladder. The whole point of all of this is to arm you with the right information so you can understand your pain and find the right path forward for you. Look, if there is one thing you take away from all this, let it be this. You cannot treat a problem effectively if you don't know exactly what the problem is. Is it the joint? Is it the nerve? Getting that right is everything. An accurate diagnosis isn't just a name for your pain, it's the roadmap to getting your life back. Because now, knowing the difference between these two conditions, you can change the entire conversation with your doctor. You can go from just saying, "My head hurts," to asking the real question. Could the pain I'm feeling in my head actually be starting in my neck? And asking that question, that could make all the difference in the world.